What are the risk factors, Dr. Nahm, for stroke? And again, I guess the symptoms are the same for men and women or not?
They're a little bit different. In the past couple of years, we've come to learn that stroke symptoms in women tend to be a little bit more atypical. Again, we mentioned acute weakness, acute numbness, acute changes of speech, language, vision, balance. All those are the classic ones. But just like in heart attack, some of the symptoms in women are atypical. Nausea, a little bit of dizziness, some atypical pain maybe. For women in stroke, cognitive changes, maybe a little confusion, or dizziness, or nausea. These are some of the more atypical ones, and are even more harder to kind of pick up.
Yeah.
So you have to be really vigilant about kind of the change, and especially the acuity of the change. Something that happens rather fast.
Yeah, out of the blue.
Yep.
And the risk factors for this, is it age? Is it lifestyle? Is it just, to use your words, out of the blue?
Yeah, age is one, gender is one. Different types of strokes we're going to talk about. Some are bleeding type strokes, some are more lack of oxygen, ischemic, so-called ischemic type strokes. Women tend to have a little higher risk for the bleeding type strokes over the age of 80. That might have something to do with the friability of blood vessels. So it's both gender as well as age are different independent risk factors. The big ones, just like for heart attacks, are high cholesterol, high lipids, high blood pressure, diabetes, atrial fibrillation or some irregularity of heart rate, family history, certain medications put you at a higher risk of having different types of stroke, like blood thinners, which paradoxically is what we use for some of the strokes as well. Right?
So you'd be using a blood thinner, but that in turn could
can also put you at risk for a bleeding type of stroke. Yep. But the big ones are really cholesterol, high cholesterol, obesity, high blood pressure, smoking, tobacco use, excessive alcohol use, irregular heart rate or atrial fibrillation, family history.
You mentioned the ischemic and hemorrhagic stroke, and I also know that there's a lot of research being done on stem cells with that. How about talking about the ischemic and hemorrhagic, the differences, and then the stem cell research that's being done?
Right. The ischemia is really a lack of oxygen. So how do you get a lack of oxygen? You get a blocked blood vessel. So if the blood vessel that's supplying a certain territory of the brain is blocked, you're not delivering blood there.
Yeah.
So there's no oxygen getting those cells. Over time, and it doesn't take much time, minutes, the neurons, the brain cells, start to decay with that lack of oxygen, and that's ischemia, lack of oxygen. So that's the ischemic type stroke. And about the majority of strokes that we see are ischemic, lack of oxygen due to something in the blood vessel. Some problem in delivery of the blood, either a clot that's sitting in the blood vessel or what's called an embolus, a little clot that may be filtered up from the heart and went upstream and blocked a blood vessel.
Yeah.
So those are the causes of the ischemic type stroke. The hemorrhagic or bleeding type strokes, that's where there's too much blood in the brain. So either an aneurysm bursts or somebody has uncontrolled blood pressure, hypertension, and those blood vessels are friable and they can burst as well. Some tumors can bleed as well. And again, that's too much blood. That's a hemorrhagic type stroke.
When someone comes in with either one of these, then what's the process, and knowing that everyone's different and the intensity obviously is different in everyone, but what is being done for that? Let's say a hemorrhagic, there's too much blood, something is really bleeding. What do you do? How do you take care of that?
Yeah, hemorrhagic stroke has been difficult for us because there haven't been a lot of therapeutics involved. Mostly involves kind of managing the complications that come from it. So once a blood vessel bursts, there's excess blood there. Now that blood causes pressure. In addition to decrease the amount of oxygen supplied to that territory, there's also a lot of pressure caused by the blood in the brain. And that pressure can affect the nerves, the neurons, the brain cells. So if it's a really big bleed, sometimes we will get our neurosurgical colleagues, and we're very fortunate in Greenwich here to have basically 5 or 6 active neurosurgeons who are on call that can actually evacuate that blood in an emergency situation. There are risks associated with that, and in the case where the person is not that symptomatic, where their deficit is mild, a little bit of weakness but not profound weakness, a lot of times we'll just watch that. We can give, if somebody's taking Coumadin or a blood thinner, we can give medications to reverse the anticoagulation to actually make the blood a little bit more thicker sometimes. There are clinical trials going on for medications that can actually increase that clotting ability in the case of an acute stroke. So that's for the hemorrhagic type strokes. Those are the major interventions there. But a lot of it is keeping them in a stable, vital status, because a lot of times there are wide fluctuations in blood pressure, in the ability to breathe. Some people need breathing support during some of these strokes. So if we can stabilize people, and this is something, getting back to your initial comment about the fear, if we can stabilize a lot of these strokes, we can get most people through it to the point where the functional outcome is good. You know, the goal is to people to return home with full autonomy. And it's really the small percentage of strokes that kind of are devastating, but it's that small percentage that really drives the fear, associated with it.
When someone is left after they leave the hospital, and again, I repeat this, that everybody's different, as we know, and they have the weakness, maybe they have a speech impediment, vision problems, but there is a chance that they're going to get better. It is a process of that individual going to therapy and then regaining his or her full ability to function as they did before, prior to this stroke.
That's correct. Again, most strokes get better. People don't realize this. Most ischemic and hemorrhagic strokes do improve to the point where you can retain your autonomy and your functionality. That's important news, and it's something that people don't hear enough, because a lot of people surf the web, and there's a lot of kind of horror stories on the web, and that's not to minimize the fear associated with it, but most strokes do get better. And the key to that, not only in the initial treatment, pre-treatment in the field, getting the emergency medical technicians to phone this information in, getting the emergency room, everything primed, getting all of the proper requirements for standard of care for stroke done in the hospital, and then that outpatient side, the physical therapy, that's a huge part of how well people do. We start them in the hospital with the physical therapy, get them walking, get them using their arms and their limbs, speech therapy if they have to. We have an excellent speech therapy program in the hospital. And then what happens when they leave? Do they go home, or do they go to a rehabilitation facility? And a lot of the recovery happens there on the recovery side.